This is Dr. Stephen Thomas, and here we have the last of 3 lectures on basic dermatology. In this case, a patient presents with 1 to 2 months of a fairly discrete area of baldness on their scalp. You can see that near the periphery there are still hairs, shortened hairs, which are snapped off at the base. Similar condition on the beard area. And this is Alopecia Areata. This is a common condition where there is a circumscribed loss of hair which occurs suddenly over normal-looking skin. There are variants of this, such as alopecia totalis, where you may lose all the hair of your scalp, and alopecia universalis, where all the body hair is lost. One point to notice here is the exclamation sign, where you basically have a normal hair, and adjacent to this you'll have a dot where the hair has snapped off. And that is fairly typical for alopecia areata. Now, we think that this is probably the result of an autoimmune process, possibly genetically based and associated with a family history of the condition and other similar conditions such as vitiligo, as well as other autoimmune conditions such as type 1 diabetes, thyroid disease, and pernicious anemia. 1 or more areas of hair loss of the scalp and or eyebrows and eyelashes develop, spread rapidly, stabilize, and then may regress. Hair growth may be permanently white. As we said, hairs which are broken, short, tapered at the base are present at the periphery of the lesion are known as exclamation mark hairs. Treatment for this: topical, intradermal, or oral steroid therapy may be of some help. Here we have a child with a sudden onset of small red macular areas on the soles of the feet and palms of the hand, and also around the mouth. This is hand, foot, and mouth disease. Hand, foot, and mouth disease is caused by a Kawasaki virus and usually affects children under the age of 10. It may start with a fever, headache, sore throat, and tiredness, and the child will develop a mild red macular eruption which becomes vesicular. There is a predilection for the hands, feet, and around the mouth. This is a self-limiting condition which resolves over 3 to 5 days, and all that is needed in this situation usually is symptomatic treatment. Here we have a young boy who has developed conjunctivitis or reddening of the conjunctiva, as well as a redness of the malar areas. Over the body, there is a red macular rash. There may be peeling of the skin over the feet, soles, hands, and fingers. And there may be quite a red, slightly swollen tongue. And this is Kawasaki syndrome, an important syndrome not to miss. Otherwise known as mucocutaneous lymph node syndrome, it is uncommon and it is a generalized vasculitic condition of children. It is an acute multi-system disorder. There is a clinical triad of fever, conjunctivitis, and skin changes, and these may include cracked red lips, a maculopapular rash, erythema of the palms and soles, desquamation of the fingertips. This is usually benign and self-limiting. However, the vasculitis may cause coronary artery aneurysms with a fatality rate of between 0.5% and 2.8%, and this is treated with immunoglobulins and aspirin. Here we have a finger, and at the base of the finger there is a white nodular area with a surround erythematous area and some erosion or keratin or crust in the very centre. If you were to incise this white area, it is solid, there is no pus, and on questioning, the patient may admit to being a farmer and working with sheep, particularly with what's known as scabby mouth. So we're looking at what's called ORF. ORF is relevant to rural areas where there is farming. It's caused by a pox virus and presents as a papule or papules on the hands of sheep handlers. It is contracted from sheep and other animals with contagious pustular dermatitis, otherwise known as scabby mouth. This is a benign condition and resolves over about 3 to 4 weeks without scarring. Here we have a young lady with a erythematous macular malar rash, which is quite confluent. And this is is not often seen, but can be a very typical finding in lupus. Systemic lupus erythematosus is a potentially serious multi-system autoimmune disorder. 85% of the time it is associated with skin lesions, such as erythematous, papular or urticarial lesions, bully, palpable purpura or vasculitis, alopecia and mucosal ulcers. This butterfly rash on the face here in this photo is sharply demarcated, erythematous, scaly, confluent, macular, with erosions and crust. On this person's back, we again have one of the presentations of lupus. This is discoid lupus. This is usually not associated with involvement of internal organs, and it's at the opposite end of the spectrum of SLE. Systemic lupus is a systemic condition which may have skin presentations, or often does have skin presentations, while in this case this is mainly a cutaneous condition with usually no organ involvement. This is autoimmune and exacerbated by sunlight. It is most common on the face. You may get erythematous plaques, and the differential diagnosis here would be psoriasis, and this can be confirmed by biopsy. Treatment of these areas consists of sun avoidance and potent topical steroids, even on the face, and this is for discoid lupus. About half of these patients go into remission after several years. In this photo, we can see someone's thigh with multiple large bullous lesions, and what can be seen is a probable biopsy site. And this is Pemphigoid or Pemphigus, or maybe one of these conditions. This is an uncommon autoimmune blistering condition. Pemphigus is the more serious of the two and can be fatal unless treated with immune suppressive drugs such as steroids, azathioprine, methotrexate, cyclophosphamide. And biopsy can be very helpful with the diagnosis, as immunofluorescence staining can show the presence and location of antibodies. This is an interesting case where a patient has developed skin changes, and important to note about these skin changes is that they are only in sun-exposed areas where the skin under clothing is not affected. And this is referred to as a photosensitivity dermatosis. A vast number of conditions can cause photosensitivity. What is important here is to recognise the distribution of the skin changes that will implicate sun exposure as a cause or contributing factor. There is a number of conditions, as we said, which can cause photosensitivity. And as we said, the important thing is to recognise that it is a photosensitivity reaction, and then you can start looking at the various potential underlying causes. Pruritis, otherwise means itch. How do we approach a generalised itch with no rash to see? In older people, generalised itch, particularly in the back, is often due to dry skin, and that can be treated with emollients, avoiding long hot showers and using soap substitutes. However, there are a number of other conditions to be aware of that may cause an itch with no rash, particularly thyroid disorder, renal failure, cholestasis, including that of pregnancy, the lymphomas, depression in the elderly, as well as various drugs such as opiates, aspirin, gold, and drugs causing cholestasis. Erythema nodosum is a vasculitic condition where someone will present with tender, raised, erythematous nodular areas, particularly in the pretibular areas, and this is a marker of underlying pathology. There is a number of conditions that can cause erythema nodosum. On this patient's hands, there are very typical lesions called target lesions. The mucous membranes may be involved with vesicular lesions. As we said, these are target-like appearance, and as soon as seeing this, the diagnosis is fairly straightforward in that it is erythema multiforme. However, erythema multiforme may be due to a number of conditions, half of which are idiopathic, but common infections such as herpes simplex and mycoplasma, as well as drugs such as penicillin, sulfonamides, allopurinol, may potentially cause this skin change to occur. We have a young person here with a red macular rash, which is becoming confluent. In this photo, it's on the trunk and upper limbs and neck. The tongue has very prominent red papillae, and this is scarlet fever. Scarlet fever is not seen as much these days, though one needs to be aware of the clinical appearance so as not to delay the diagnosis. Scarlet fever is caused by strep pyogenes producing an erythrogenic toxin. Usually starts as a sore throat, fever, vomiting, and then a rash on day 2. There will be punctate red blanching spots on the skin, which rapidly become generalized. There's circumoral pallor around the mouth, as well as the strawberry-appearing tongue that we showed in the previous photo. Throat swabs can be used for antigen testing and culture. There is serology testing available, and the condition responds well to penicillin. Here we have blebs forming in the skin, solid blebs, otherwise known as hives or urticaria. And this is a form of urticaria which is caused by friction or pressure on the skin. So here we'll be covering urticaria and angioedema. Urticaria is a localized, itchy, transient area of skin edema which begin as small and then generally coalesce. It's also known as hives. Angioedema is a similar reaction, though in the subcutaneous tissues, causing large areas of swelling, especially around the face. These can develop quickly and can resolve reasonably quickly as well. This tends to be recurring and changing, so different on each episode. Hives or urticaria is due to mast cell degranulation, causing leakage of fluids into the subcutaneous or dermal spaces. Here is angioedema, where you have quite prominent subcutaneous swelling of the upper lip. And there are a number of different causes. Allergic, say to foods or drugs, contact allergies, say to latex. There are physical causes. These are uncommon to rare, such as reactions to water, cholinergic reactions such as to anxiety, heat or exertion, the cold, pressure, which can cause a delayed or immediate reaction, heat, vibration, sun exposure. There can also be a hereditary or acquired angioedema due to C1 esterase deficiency. The treatment involves avoiding underlying causes. Antihistamines, H1 blockers may be effective, and you may add on to this H2 blockers such as cimetidine. A short course of oral corticosteroids may be a benefit, and adrenaline may be required in emergency situations, particularly if angioedema of the upper airway. Here we have the legs of a person with red macular areas, and it is important to point out in this situation that these areas do not blanch with pressure. And this is a vasculitis. The small vessels of the skin become inflamed, blocked, leak, and these are basically the leaking of blood into the tissues, and so will not blanch with pressure. So as we said, this is caused by vascular inflammation, often presents as tender, palpable, erythematous nodules or macules, otherwise known as palpable purpura, due to bleeding under the skin. There are many different types of vasculitis, such as chilblains, where there is cold injury leading to lymphocytic vascular damage, erythema nodosum, which we covered, and Henoch Schoenlein purpura, just to name a few. Often there is no underlying cause that can be found, but it does require full investigation to rule out any underlying disease. Here we have a child with this vasculitic type rash, particularly on the buttocks, hamstrings, lower legs, and some on the arms. And this is Henoch Schoenlein purpura, one of the types of vasculitis we were talking about. It is a vasculitis associated with IgA deposition, usually occurs in young children. The classic triad is palpable purpura, usually on the legs and buttocks, arthritis and colicky abdominal pain. There is renal involvement and hematuria in about 40% of cases. Most episodes are self-limiting and only require symptomatic treatment. Relapse may occur in up to 1 out of every 3 cases. Permanent kidney damage occurs in about 1 in 100 cases. And it may be triggered by bacteria, viruses, or drugs, though the exact cause is often unknown. Again, here we have red to purplish macular areas which do not blanch with pressure. This can progress to necrosis, which is very serious, and this is meningococcal septicaemia. By the time you see a rash like this, the person is usually critically ill. It's caused by Neisseria meningitidis. It's carried asymptomatically by about 20% of the population, and it can cause meningitis and septicemia. There is a rapid onset with a 5 to 10% mortality rate, and it causes a hemorrhagic, purpuric, non-blanching rash in an unwell patient. Treatment is urgent, usually with IMI or IVI penicillin, even before transfer to hospital. Here we have a child with quite red cheeks, a red confluent rash on the cheeks, with also some rash seen on the rest of the face, trunk and upper limbs. This is called slap cheek syndrome and is characterized by the intense erythema of the cheeks, either one cheek or both cheeks. This is also known as erythema infectiosum or fifth disease, and it's caused by parvovirus B19. Patients also develop a red lacy rash on the rest of the body, and it's usually a mild, self-limiting disease lasting several days and which becomes non-infectious once the rash appears. Pregnant women are at risk as the infection can result in miscarriage. Here we have a young girl who has come out with crops of vesicles on erythematous bases. On close inspection, we can see the vesicle. The erythematous base is not as obvious here. And this is chickenpox, herpes varicella. Herpes varicella infects about 98% of the adult population. I should clarify that to say it's usually developed as a child but will persist into the adult population. 90% of cases occur in children under 10, and the incubation is anywhere from 10 to 23 days, which for a mild case may make diagnosis difficult because the patient may not recall being in contact with a known case of chickenpox, seeing that the contact may have been up to 1 to 2 to 3 weeks previously. Patients with constitutional symptoms such as tiredness, fever, aches and pains, and the vesicles are itchy, and as we said, on an erythematous background, and they develop in crops which can then form into pustules and erode, becoming scabby. The patient remains infectious until the sores have all crusted over. The disease may be quite subtle due to widespread vaccination. And then we have a lot of viruses, Rubella, Measles, and many other viruses, which can cause constitutional symptoms, being unwell, low-grade fevers, cough, runny nose, and a generalized macular rash on the body. These are difficult to elicit the underlying exact virus without serology, though usually is not necessary, as most often these conditions are self-limiting. So these viruses can present with a widespread erythematous macular rash, which may be slightly itchy. It is associated with constitutional symptoms such as fever, tiredness, aches and pains, or URTI, upper respiratory tract type symptoms. There may be subtle differences in the rash, development of the rash, and other signs which can help differentiate between the infections, and it's worth being familiar with these symptoms. However, signs can be subtle with widespread MMR, mumps, measles, rubella vaccination. Measles and rubella are both notifiable diseases in the interest of public health. such as vaccination patterns and outbreak surveillance. Here we have probably an elderly person with a large ulcerated area over the malleolus, and while not overly visible in this photo, there is probably edema of the lower leg. Again, these ulcers can be quite extensive and chronic, and these are venous leg ulcers. Interesting to note that treating leg ulcers takes up approximately 2% of the UK's health budget, so it is a serious concern. It affects about 2% of those over 80, and venous obstruction, such as a previous DVT, or valve incompetence, such as varicose veins, leads to venous hypertension, swelling, brown discoloration due to hemosiderin deposition, induration of the skin, and then ulcer formation. Ulcer recurrent rates are high due to the persistence of the underlying venous problems. Other factors to consider when looking at patients with venous ulcers is what the arterial circulation may be like, to exclude a malignant ulcer. There are other conditions such as diabetes or anemia, and is there any sign of infection in the wound? The venous ulcers are best treated by an experienced team using the modern hydroactive dressings, which provide a microenvironment to assist with healing, elevation of the limb to reduce swelling, as well as compression to, again, reduce swelling and help the area heal despite the underlying venous disease. However, you need to be aware that if there is presence of arterial disease, this may contraindicate the use of pressure, as the pressure will decrease circulation to the leg and foot. That is the end of the third lecture. I hope you've had some learning and benefit from the 3 lectures. If you have any comments, please feel free to leave them down below. Thank you for listening.